Hi, my name is Eirik Salvesen, and today I'll talk to you about full-arch immediate loading. Edentulism remains a very real problem for millions of people around the world. The World Health Organization even goes so far as to classify it as a physical impairment. And it is on the increase. Although reports have identified an overall improvement in oral health globally, as more people live to reach old age, the number of people suffering from edentulism continues to rise. This represents an incredible chance for dental professionals to make another constructive contribution to patients' quality of life. In systematic reviews, no significant difference is found in terms of success between conventionally loaded and immediately loaded implants in full-arch treatments. However, patient satisfaction is highly ranked in immediate treatments. In this treatment modality, the implants are linked by a supragingival prosthetic bar providing cross-arch splinting, so no implant takes the loading forces alone. Full-arch treatments is also an opportunity to establish an idealized version of the patient's occlusion and function, as well as to harmonize the overall patient's aesthetic condition. When performing full-arch immediate loading procedures, the following recommendations should be considered to maximize success. Adequate number and distribution of implants to provide your cross-arch stabilization. Good initial stability of the implants with a minimum insertion torque of 35 Newton-centimeters. Work on abutment level so that the prosthesis does not have to be seated deep in the surgical wound area. A passive fit of the provisional restoration is important. Adequate and sufficient vertical space should be present for the strength of the provisional restoration. Balanced occlusal contacts. Cantilevers should be avoided, and removal of the provisional restoration should be avoided as much as possible during the osseointegration period. Patients with parafunctional habits may not be your ideal candidates for this treatment protocol. At ORES, patients receiving full-arch immediate loading procedures are seen after 2 weeks for control of the wound area and also control of the prosthesis. After 4 weeks, we take them back for cleaning, very often discolorations coming from the chlorhexidine rinse they used post-operative. At 8 weeks, we see them for an X-ray control and then start the planning for the final prosthesis. When the final prostheses are positioned and in place with our patients, we see them every 3 months until the opposite is proven. So patient characteristics like oral hygiene, initial diagnosis for tooth loss, smoking, diabetes are all factors to be considered when you are deciding for the maintenance care for the patient. In our clinic, we consider immediate loading as the option by default. However, the following factors might not make this possible. Not enough bone volume, ongoing acute and extensive infections affecting the bone volume, patient characteristics such as systemic or local conditions that reduce the healing capacity of the patient, logistical issues either on the patient side or on the clinic side. When it comes to planning, immediate full-arch procedures require more preparations, as a pre-operative complete tooth setup has to be produced. Regarding the implant distribution, the priority is to achieve a good spread, but the number of implants will depend on the bone availability. As to my prosthetic preference, we work with acrylic for the temporary restorations. That's all I wanted to share with you on full-arch immediate loading. I hope it brought you something, and I do hope that your interest in immediacy is increased and you will explore this option in your own clinic.